So we'll start with the different tests for the diagnosis of mouth breathing. So the first test is definitely your visual examination. So in visual examination, what you check is regarding the size, shape, activity of your external nerves. You can see that the nose is upturned. The nose has got a broader opening and all. So that is because that is what you see in the visual examination of mouth breathing. Now, the second test is regarding your mirror test, which what we use is a two-surfaced mirror. So this has what you generally use is a single surface mirror, right? But in mirror test, you use a double surfaced mirror. Since there are two surfaces in the mirror, you can check for the fogging, which area it fogs. What you do is that you will place the double surface mirror over in this aspect, and if the nasal part is fogging, you can understand that the child is breathing through the nose. But if the area of fogging is towards your mouth, that shows that the patient is a mouth breather. That is how you perform a two-surfaced or a double surface mirror. What you do is that you place a double surface mirror between your nose and your mouth, and you check where the area is getting fogged. Okay, now the third test for mouth breathing is a butterfly test. So a butterfly test means you place a butterfly shaped cotton between your nose and your mouth, and what you see, and you'll observe where the cotton will flutter. So if the cotton is fluttering towards the nasal cavity, that shows that the child is breathing through your mouth. And if the cotton flutters downwards, that shows that the child is breathing through the nose. That is how you do a butterfly test to diagnose the mouth breathing. Now, the fourth test is your water holding test, which you commonly practice chairside, right? What you do is that you will ask the child to take a mouthful of water, and you'll see how long the child can withstand or retain that water in the oral cavity. Normally, the child will be able to retain it for around 1.5 to 2 minutes. But a mouth breathing child or the child with mouth breathing habit will not be able to hold it for more than 45 seconds or more. So that is how you diagnose mouth breathing by the water holding test. Now moving on to the next test, that is the rhinometry. So this is one common MCQ question that you get from mouth breathing, which is the kind of more definitive diagnostic test in mouth breathing. So the answer for that is rhinometry or rhinomanometry, or otherwise called the inductive plethysmography. So in rhinometry, what you do is that the total airflow through the nose and mouth is quantified. What you measure is the total airflow through your mouth and nose. So that is how it becomes a relatively more reliable or a more diagnostic point of view. So this is kind of a reliable method among all the methods to assess the mouth breathing habit. Now, the last method that we commonly use is your cephalometrics, which you use to calculate the amount of nasopharyngeal space. Okay, so the most common question which you get from diagnosis is the most reliable method to diagnose mouth breathing, and the answer for that is rhinometry or inductive plethysmography. Okay, now we'll see what are the features in mouth breathing. So in a mouth breathing child, you know that the child is breathing through the mouth, right? So in order to get a proper breathing pattern, the child will have to need to bend the neck forward. That will straighten the oronasopharyngeal path, and that will give a typical pigeon chest appearance. So this is the picture of a pigeon chest. So it is actually a malformed chest due to the prominence of your breastbone. Okay, so this is a picture of a pigeon chest. So in order to breathe, the child will bend the neck forward, straightening the oronasopharyngeal path, giving the appearance of your pigeon chest. And also you can see that in mouth breathers, because of the constant mouth open position, you can see that the oropharynx is dry and can produce a low-grade esophagitis. And also in them, the maxillary sinus and nasal cavity will frequently become narrowed, the turbinates become swollen and engorged, and the speech appears a nasal tone. Also, the blood gas studies will reveal that the mouth breathers are having 20% more carbon dioxide and less oxygen. Because they are breathing through the mouth, the percentage of carbon dioxide is more when compared to that of a nasal breather. So these are the important general features which you need to know in mouth breathing. Now moving on to the profile of a chronic mouth breather. So the typical facies or the typical facial pattern that you see in mouth breathing is referred to as the adenoid facies. So adenoid facies means a long, narrow face. So in adenoid facies or in a typically in the profile of a chronic mouth breather, you can observe that there is a flattened nose. You can see an upturned nose, and also there is a short upper lip as shown in the picture. There is a short upper lip. There is a receding chin or a chin is receded in mouth breathing child, a superiorly tipped nose, a long narrow face, what you called your adenoid facies, and an expressionless face with a flat nasal bridge. You can see that the child is having a forward head posture as the child is breathing through the nose. So these are the typical features that you see in the profile of a chronic mouth breather. So these are the main extraoral features that you see. Now we'll just compare what is the main changes that you see between a mouth breather and a nasal breather. So in a nasal breather, you can see that there is a good definition of cheekbone, a wider face, good airway size, well-developed jaw, and a straight nose. But at the same time, in mouth breathing, you can see that there is a poor definition of your cheekbones, crooked or malaligned teeth, a long narrow face, tired eyes, again a crooked or upturned nose, smaller airways, and a retrognathic or a set back jaw. So these are the features which you see extraorally. These are the main features that you need to know to distinguish between a nasal breather and a mouth breather. Now about the dental effects. So dental effects, because of that open posture of the mouth, definitely you know your buccinator mechanism, that is the pressure between the cheeks, tongues, everything, all that balance will be lost. So because of that, you can see a proclination of your upper anteriors, spacing of your upper anteriors, and also a narrow maxillary arch, posterior cross bite, anterior open bite, and typical gingivitis that you see is a anterior maxillary gingivitis. Because the mouth is always in an open position, you can see an anterior marginal maxillary gingivitis in the case of a mouth breather. Okay, so these are the main dental effects following a mouth breathing habit. Now about the skeletal effects. So in the skeletal effects, you know that there is an increased mandibular plane angle. Then as we have already mentioned, a setback jaw or a retrognathic mandible and an increased lower facial height. So these are the skeletal effects that you see in mouth breathing. Now regarding the treatment of mouth breathing. So definitely the treatment of mouth breathing is to eliminate the underlying cause. As we've already mentioned, the obstructive mouth breathing is due to obstruction of your airway. That might be due to your nasal polyp, your deviated nasal septum, allergic rhinitis, infections, inflammations, anything. So first thing what you have to do is to get for an ENT consultation and see whether and to eliminate the underlying cause that leads to the mouth breathing habit in the child. Now, secondly, what you can do is deep breathing exercise that will facilitate the child to breathe through the nose. Then what you can do is a lip exercise. As we have mentioned, in mouth breathing, you see hypotonic upper lip. So to overcome that, you can do certain lip exercise around 15 to 30 minutes a day for around 4 to 5 months. And finally, the appliance therapy in mouth breathing is your oral screen. Now the questions again from oral screen would be, who introduced oral screen? So oral screen was introduced by Nivelle. So Nivelle is the person who is behind the introduction of oral screen, and it is a myofunctional appliance that takes the form of a curved shield of acrylic placed in the labial vestibule, extending from molar on one side, covering anteriorly to the molar on the opposite side. So this is your oral screen. So probably you might be knowing everything about oral screen. Now we'll see what are the basic modifications or what are the mechanism of action of an oral screen. So as we have mentioned, once you place the oral screen, it will shield the tooth. It will shield or protect your teeth from the inadvertent forces exerted by your cheek, your tongue, etc. and it will produce a slight mandibular advancement. It will improve the tonicity of your upper and lower lip. Actually, the upper and lower lip in mouth breathing is hypotonic. So once you place an oral screen, it will increase the tonicity of your upper and lower lip. And once the pressure of your lip, the pressure of the lip will be transmitted to the incisors through the medium of your oral screen. That will lead to the retraction of your maxillary incisors, and also will helps in the mild intrusion of your maxillary incisors. So the basic action of your oral screen is that it prevents the muscle force from acting on the dentition. Okay, so this is the mechanism of action of oral screen. Now about the modifications of oral screen. So you know in your NEET exam you get a lot of picture-based question. So the modifications of oral screen are again typically very important. So the first modification of oral screen is your HOTS modification, or the one that is seen in the picture. Okay, so oral screen or a HOTS modification of oral screen is the oral screen with a metallic ring. You can see that there is a metal ring or a wire loop is present in this oral screen. So what is the main function of this wire loop or this metallic ring? The main function of the metallic ring is to facilitate lip exercise so that you can improve the tonicity of your upper lip. Okay, so this is the first modification of oral screen, that is the HOTS modification of oral screen. Now, the second modification is a double oral screen. So double oral screen means that in patients with tongue thrusting habit, you place an additional shield. As the name says, there is double oral screen. That is, two shields are there. One in the buccal aspect and the one in the lingual aspect. That is an additional screen in the lingual aspect of the teeth is also seen. So the main function of your double oral screen is that in addition to correction of your mouth breathing, you will get habit corrections like habit correction of habits of your tongue thrusting also. Okay, so again, this modification of oral screen, that is a double oral screen, is given by cross. Now, the next modification of oral screen is the oral screen with breathing holes. So what is this oral screen? You can see that numerous breathing holes are there, right? So oral screen with breathing holes means that you fabricate an oral screen with various holes, and these holes are later closed in a phased manner so that you are not immediately troubling your child with by placing a full coverage shield all over your tooth. Okay, so what you do is that you actually place various holes and you close the holes in a phased manner, so gradually, so that the child can adapt well to your oral screen. Okay, so this is the third modification of oral screen, that is oral screen with breathing holes. So again, this modification was given by cross. Now moving on to the rehack modification of oral screen. So rehack modification of oral screen is the oral screen with a nipple-like acrylic projection on the labial side, which is retained by the lips. Okay, so an acrylic projection. So it has got an acrylic projection on the labial side, which is retained by the lips to simulate the natural sucking movement. So this is the fourth modification of oral screen, that is the rehack modification of oral screen. Okay. So one last topic which I would like to cover regarding oral screen is about the difference between the vestibular and the oral screen. Are they one and the same? So according to Cross, there is basic difference between your vestibular screen and your oral screen. So oral screen, you know, you are giving it for controlling of many abnormal habits like your mouth breathing, tongue thrusting, thumb sucking, lip biting and all. And in oral screen, as we have already mentioned in the mechanism of action, there is a teeth contact present with the acrylic of your oral screen, right? But at the same time, in a vestibular screen, it is a particular screen which is extended into the vestibule and it contacts with the alveolar process, and there is no other teeth contact. Okay, they are otherwise called a lip molder and they can be used in the correction of your mouth breathing habit. But the thing is that there is no teeth contact in the case of a vestibular screen. Okay, so that is about the basic theory aspects which you need to know in the mouth breathing habit. Okay, so these are the main, I'm not going into the detail of mouth breathing habit. We'll just cover the in brief about the total mouth breathing habit. Now we'll move on to the questions in the session. You can use your chat box to give the correct responses. So the first question is, one of the following is not a type of mouth breathing. So which is that? Which is not a type of mouth breathing? Yes, it is physiological. What do you mean by an anatomic mouth breathing? What do you mean by an anatomic mouth breathing? Or what is the cause for an anatomic mouth breathing? Yes, I got a correct response. That is short upper lip. The cause for an anatomic mouth breathing is a short upper lip. Now, what do you mean by a habitual mouth breathing? What do you mean by a habitual mouth breathing? Yes, even after the removal of your obstructive force, you still continue that habit. You call that a habitual mouth breathing. Now, what do you mean by an obstructive mouth breathing? What are the causes of an obstructive mouth breathing? You know, there are, yes, adenoids, polyps, infections, allergic rhinitis, deviated nasal septum. All this will lead to a obstructive mouth breathing. Now you tell me, who has given this classification of mouth breathing? The classification, yes, very good. It is Finn. So that is about the different types of mouth breathing. I hope I am clear to you all about this topic. So if you have any doubts regarding this question, you can use the chat box. Okay, so now we'll move on to the next question. That is, the only reliable method for determining the mode of respiratory function is? Yes, correct. It is inductive plethysmography, or what is the other name for that? Yes, rhinometry. Both of them will measure your space or the amount of expirate through the through the nose as well as your mouth. So remember what butterfly test was? You place a cotton between your between your nose and your lips, and you'll see where the cotton flutters. So if it's fluttering upwards, that shows that the mouth breathing habit, or if it's fluttering downwards, that shows that the child is a nasal breather. Then you know about the water holding test. Then what were the other tests in the diagnosis of mouth breathing? You have cephalometrics, you have visual methods, you have a double-sided mirror test. Okay, and you check which area it fogs to determine whether the child is breathing through the mouth or through the nose. Okay, so the correct answer for this question is inductive plethysmography or rhinometry. Now, oral screen was introduced by? Yes, oral screen was introduced by Nivell. Now you tell me, what is Andreessen associated with? What is Andreessen associated with? Anybody? No answers? Malocclusion classifications other than that? Which is there any myofunctional appliance Andreessen is associated with? Any appliance? No answers? Frankel. Is it Frankel? See, Andreessen is associated with activator. Okay, so activator was introduced by Andreessen. Okay, I hope I am clear to you. Andreessen is associated with activator. Now, what is cross associated with? What is cross associated with? What is a cross and what is the relationship with cross and yes, not only double screen, most of the modifications of oral screen were given by cross. Okay. Now, what is fin associated with mouth breathing? How is fin related to mouth breathing? How is fin related to mouth breathing? Yes, Finn has given the classification for mouth breathing. Okay, so now we'll move on to the next question. So in a mouth breather, the tonicity of your upper lip is, yes, correct. It is decreased. In a mouth breather, the tonicity of your upper lip is decreased. So why do you do a lip exercise in mouth breathing? What is the main significance of doing a lip exercise in your mouth breathing? No answers. Lip exercises in mouth breathing is done to increase the tonicity of your upper lip. Yeah, that is it. To increase the tonicity of your upper lip so that you can get a better lip competence, right? So that is why you do lip exercises in mouth breathing. Now, tell me, mouth breathing with enlarged adenoids and tonsils may be best described as which class of mouth breathing? Yes, it is obstructive mouth breathing. Correct. I think there is no confusions again. Anatomy is due to short upper lip. Now, in adenoid facies, the facial profile is, yes, it's correct again. It is long and narrow. Okay. So in adenoid facies, the facial profile is long and narrow. Now, moving on to the next question. A patient is involved in chronic mouth breathing, and the clinical examination of the patient will reveal what? Yes. The clinical examination will reveal a convex profile, long face, and narrow arches. I think one of you have mentioned the option as D. See, in mouth breathing, you see a convex profile because you have already mentioned that there is a low setback jaw or a receding chin. So definitely you'll see a convex profile. Then in mouth breathing, again, you see adenoid facies. So adenoid facies is the typical pattern of an adenoid facies is that you see a long, narrow face. And definitely because the buccinator mechanism is compromised, you see a narrow arches. So the best option in this question is a convex profile, long face and narrow arches. I think I'll move on to the next question. Now, the effect of enlarged adenoids on the maxillary growth is by, the effect of enlarged adenoids on the maxillary growth is by, Yes, I get a lot of correct responses. The effect of enlarged adenoids in the maxillary growth is mainly it will cause a narrowing of your maxilla. Now we'll just exclude the other options. You know that widening of maxilla is not seen in mouth breathing. Now, palatal plane tipped upwards at PNS. Just imagine this clinical scenario. If there is an enlarged adenoids, adenoids are there in the posterior aspect, right? If there is an enlarged adenoid, will the palatal plane tip upwards at the PNS? No, no. So you can easily exclude that option. And also you can, and the palate, does the palate descends down due to the enlarged adenoid? Again, no. So the better answer for this, that is the effect of enlarged adenoids on the maxillary growth is, the better option is narrowing of your maxilla. Okay. Now we'll move on to the next question, or probably the last question. Which of the following cephalometric parameter is used to diagnose a long face syndrome patient? Which of the following cephalometric parameter is used to diagnose a long face syndrome patient? Read the question properly. Which of the following parameter is used to diagnose a long face syndrome patient? I'm getting multiple options. Yes, I got A, B, C, D. Okay, so I'll help you with the answer. Long face syndrome patient means definitely the child is having it might be due to many reasons, but mouth breathing is one cause for the long face syndrome. So the answer for this question is a Jarabak ratio. So what do you mean by a Jarabak ratio? So Jarabak ratio is actually given by the formula, that is a posterior facial height divided by your anterior facial height into 100. So if the ratio is less than 62%, it shows that the child is having a vertical growth pattern. And if it is more than 65%, shows that the child is having a horizontal growth pattern. Okay, so Jarabak ratio is posterior facial height by anterior facial height into 100. Okay, so if you get a lower ratio, that shows that it's a vertical growing pattern. And if you get if the ratio is more than 65%, that shows that the child is having a horizontal growth pattern. I'll just explain the options in this question. I'm not going into details of cephalometrics because that won't be that won't be completed in half an hour or 1 hour even. So I'll just explain the other options for those who have mentioned SNA, SNB, and ANB. Okay, so what do you mean by your SNA or your sella nasion point A angle? So you know that your sella is the midpoint of the pituitary fossa or the sella turcica. That is what you call your sella point. Okay, and nasion is the most anterior point in the midway between the frontal and nasal bone. That is called your nasion. Then you have a point A, which is the deepest part in the midline between your anterior nasal spine and the alveolar crest between the two central incisors. So this is your soft tissue point A. Okay, so a line connecting your SNA, that is called your SNA angle. So what it represents? It actually represents the position of your maxilla. This point A is there in your maxilla, right? So it represents the position of maxilla with respect to your cranial base. So SNA mentions the maxilla, the relation of maxilla with respect to your cranial base. So the normal value for SNA is 82 degree, that is plus or minus 2 degree. Okay, so that is your first option, that is SNA. Now your second option was SNB, right? So SNB is actually the angle formed between the SN plane, that is again your sella nasion plane, and your point B. So what is your point B? It is the deepest point in the midline between the alveolar crest of the mandibular incisors and your mental process. That is your soft tissue point B. So SNB is your line connecting SN and your nasion to point B. Okay, so what SNB measures? It measures the position of your mandible in relation to the cranial base. Okay, SNB measures, SNB angle measures the position of your mandible in relation to the cranial base. And the mean value for SNB is again 80 degree. For SNA it was 82 and for SNB it is 80 degree. Now the third option was Jarabak ratio and the last option was A and B, right? So A and B means your SNA minus SNB. So what it actually measures, it represents the sagittal or the anteroposterior relation of maxilla with that of mandible. Okay, it represents the anteroposterior relationship of maxilla with that of mandible. So if there is a negative value, you can negative value of A and B shows that there is a class 3 skeletal base, and if the A and B value is more than 4, it is considered to be a class 2 skeletal base. The mean value of A and B will be definitely 2 degree, right? Because 82 is for SNA, 80 is for SNB. So what will be A and B? It will be 2 degrees. The mean value is 2 degree. So if you get a negative value, that shows that the child is having a class 3 skeletal base because the mandible is prognatic or the point B is more forwardly placed. Right? Now, if the value is more than 4 degree, that shows that the child is having a class 2 skeletal base. Okay, I'm not going into details into cephalometrics and all. I'll just explain the options in this question. So you have SNA, SNB, A and B, and the last option was Jarabak ratio, right? So SNA mentions the relationship of your maxilla to the cranial base. SNB mentions the relationship of your mandible to cranial base, and A and B represents the maxillomandibular relation in the anteroposterior plane. Okay, now you read the question again. That is, which of the cephalometric parameter is used to diagnose a long face syndrome patient? Now what the answer will be? A and B. What does A and B measures? A and B measures your what? Relationship of the maxilla and mandible in an anteroposterior plane, right? SNA measures your relationship of your maxilla to the cranial base. And what was Jarabak ratio? It is posterior cranial height, posterior facial height by anterior facial height. That would be the best answer for this, right? So this, the best cephalometric parameter to diagnose a long face syndrome patient or something like what you see in mouth breathing, the answer is Jarabak ratio. Okay, I hope the question is clear to you all. Am I clear to you all regarding the question? Yes, right? Okay. So that finishes our session. We'll be planning a very brief session on mouth breathing. I know it is very brief and probably you might be knowing all this. I'll just brush through the headings, which that's what actually meant in this webinar. If you join in, you'll get in the detailed response or the detailed classes regarding various habits and various pediatric conditions. So I think I've come to the end of today's presentation. And if you have any doubts, you can either use the chat box or you can message me personally. And we'll just have a brief about the next webinar. The next webinar will be conducted by Dr. Uday Banu on 25th July. So thank you all once again. Over to you, Dr. Naufira.
Thank you, Dr. Sharin, for this beautiful session. Okay, now we have enough time for the next upcoming webinar. And yeah, I hope you had a detailed session on the, how we approach these subjects on when it comes to MCQs. So we can meet with the next webinar and stay prepared. Okay, it's from Dr. Uday. And thank you so much, Dr. Sharin, for this session once again. And good night.